A 28-year-old male presents with bilateral hip pain and stiffness. I am showing you the pelvic radiograph. Describe the findings.
Let me just study this for a second. Right. The pelvic radiograph demonstrates severe bilateral irregularity, fragmentation, and flattening of the femoral heads. There is marked joint space narrowing, subchondral sclerosis, and large subchondral cyst formation, indicating advanced premature osteoarthritis. Crucially, there are multiple calcified foci with lucent centers in the periarticular soft tissues of both hip joints, consistent with synovial osteochondromatosis. In summary, there is bilateral irregular femoral head dysplasia leading to premature osteoarthritis and secondary synovial osteochondromatosis. The underlying cause of this dysplastic appearance is Meyer's dysplasia.
What is the differential diagnosis for stippled or irregular femoral head epiphyses, and how do we distinguish between them?
The differential diagnosis for irregular epiphyses includes avascular necrosis, multiple epiphyseal dysplasia, Meyer's dysplasia, Morquio's syndrome, congenital hypothyroidism, and chondrodysplasia punctata. We can distinguish Meyer's dysplasia from multiple epiphyseal dysplasia because Meyer's is strictly confined to the upper femoral epiphyses, whereas multiple epiphyseal dysplasia is systemic and affects the knees, ankles, and tarsal bones. Avascular necrosis typically presents with risk factors such as steroid use or sickle cell disease, which can be identified by ancillary signs like vertebral end plate infarctions or pelvic transplant kidneys.
Discuss the pathophysiology of synovial osteochondromatosis and differentiate between the primary and secondary forms.
Synovial osteochondromatosis is characterized by benign metaplasia of the subsynovial connective tissue, where it differentiates into cartilaginous nodules. These nodules grow, calcify, and eventually detach from the synovium to become free-floating loose bodies within the joint space. Primary synovial osteochondromatosis occurs in otherwise normal joints and features numerous small, uniform, round calcified bodies. Secondary synovial osteochondromatosis develops in joints with pre-existing pathology such as osteoarthritis. In the secondary form, the calcified bodies are typically fewer, larger, and demonstrate highly variable sizes and shapes with lucent centers.
What are the key clinical features of Meyer's dysplasia, and what are its long-term skeletal implications?
Meyer's dysplasia, also known as congenital multicentric ossification of the femoral heads, is a rare developmental dysplasia. It typically presents in young children between 2 and 6 years of age as an asymptomatic limping or mild hip pain. Radiographically, it shows delayed, irregular, stippled, and fragmented ossification of the femoral heads. Although the femoral heads can completely normalize in shape during childhood, some cases progress to permanent deformity, leading to incongruous joint surfaces and the development of severe, premature osteoarthritis in early adulthood.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing this pelvic radiograph with prior pelvic films to assess the rate of joint degeneration and the migration of loose bodies. I would suggest obtaining a non-contrast MRI of both hips to evaluate the remaining articular cartilage, assess the extent of subchondral edema, and better delineate the intra-articular loose bodies. I would communicate the finding of secondary synovial osteochondromatosis and premature osteoarthritis to the referring orthopedics team. Finally, I would recommend supportive management and referral for eventual total hip arthroplasty.